Hi, this is Dr. Manish Patel, a medical oncologist, hematologist. I'm the director of drug development at the Florida Cancer Specialists and Research Institute based out of Sarasota, Florida. Today is a CME program looking to discuss the emerging role of B7-H3 targeted antibody drug conjugates. So there's a lot of unmet needs within the therapeutic areas in oncology, and many targets have been identified, and B7H3 has certainly become more popular in terms of therapies that are out there to target. B7H3 is a transmembrane protein, and as you can see on this slide, we're showing all the current immune checkpoint receptors and their ligands. You can see on the top the tumor cells, APCs, and on the bottom the T cells. What's interesting about B7H3, and it has a lot of immune interaction, but the receptor for B7H3 has not been clearly identified. So B7H3 ligand inhibits the activity of immune cells. So it serves a co-inhibitory function as well as a co-stimulatory function. So there's certainly many interactions that B7H3 has and interactions with the immune system and immune cells. Besides the immune interaction, when B7H3 is activated, it often increases the fibroblast proliferation, progression, migration, and inhibits apoptosis. When B7H3 is activated, it promotes tumor cell growth, enhances tumor cell metastases, and plays a role in the modulation of cytokine secretion in many tumor microenvironment cells, and also through remodeling. So many interactions of B7H3, not only on the immune side, but also the tumor microenvironment side. So B7H3 ligand is overexpressed in multiple solid tumors. You can see here on this slide, but most, and we'll be going through this today. This includes prostate cancer, esophageal cancer, small cell lung cancer, squamous non-small cell lung cancer, and we'll go through some of the data on some drugs that target B7H3 in those tumors. So speaking of B7H3, so there are antibody drug conjugates that have been developed to target B7H3, and this is one of them. Ifinatamab, deruxtecan, also known as DS7300, was studied in this particular phase 1 trial, and I had the opportunity to participate in this trial from the very beginning, the first cohort. And we presented this at ESMO in 2023. So here's a structure of DS7300. Obviously, it involves a humanized B7H3 monoclonal antibody and attached to a deruxtecan. So the payload is a topoisomerase 1 inhibitor, a potent payload linked with a stable cleavable tetrapeptide-based linker. And this was the phase 1/2 study design that we conducted, that we presented at ESMO. Initially, patients with advanced, unresectable, or metastatic solid tumors were enrolled. These were unselected for B7H3, so over 200 patients were involved in this trial, and it's still ongoing. In terms of dose escalation, it moved all the way up to 16 milligrams per kilo, and 16 milligrams per kilogram was felt to be too toxic, and so 8 milligrams per kilo and 12 milligrams per kilo were further studied in certain populations. As you can see here, that there were 3 particular cohorts in the dose expansion phase: squamous esophageal cancer, metastatic castration-resistant prostate cancer, as well as squamous non-small cell lung cancer. And so the primary, in terms of primary endpoints and dose escalation, DLTs, of course, treatment-related adverse events and adverse events of special interest, and of course the dose expansion, overall response rate, duration of response, progression-free survival, and overall survival was followed. So in terms of the efficacy results, we're showing the subset populations. Small cell lung cancer, in terms of this population within the phase 1 trial, was certainly remarkable. As you can see here, although small numbers, 21 patients in the efficacy population, the sponsor determined that anything of 4.8 milligrams per kilo or above was the efficacious or efficacy population. So there was about 21 patients when they went back and looked at. So small numbers. However, almost every single patient had reduction of disease, as you can see here in the waterfall plot. Around 52% overall response rate. The median progression-free survival in this small population was 5.6 months, but the median overall survival was 12.2 months in this extensive stage small cell lung cancer population that was refractory to prior therapies. So, pretty impressive for this group. Within the squamous esophageal cancer group, you can see here, once again, small numbers, 28 patients, but you can see at the waterfall plot and the overall response rate on the far right, about 21% in that population, overall survival of 7 months. And this was a relatively heavily pretreated population, a median number of prior lines of 4, and with metastatic esophageal cancer. And this is kind of the target that we see with all B7-H3 agents is the metastatic castration-resistant prostate cancer population. You can see a good number of patients were part of this subset in this trial, 73 patients that were just part of the efficacy population. And as you can see here, it's hard to, it's more and more difficult to find these patients with measurable disease with prostate cancer. But certainly of the patients that had it on this trial, you can see the overall response rate of 25%. And then of the patients who had liver mets, which I find very interesting, 33% there was 33% overall response rate. So, biopsies were not performed on this population prior to coming on trial. So we don't truly know how many of these may have had neuroendocrine features, for example. But when you see patients with liver mets and with metastatic prostate cancer as responding in this fashion, it's certainly exciting. Median overall survival with this group was 13 months in a heavily pretreated population. You can see there the number of prior systemic therapies was 6 in this phase 1 trial. Median progression-free survival is 5.3. So we're seeing this kind of activity with other B7-H3 targets, and certainly was displayed here in our ESMO presentation. And then within our squamous non-small cell lung cancer population, small numbers, 13 in the efficacy population, but you can see here certainly there was activity there. Overall response 30%, duration of response 4 months. But once again, these patients had a median of 3 prior lines. There's more that's going to be studied with this population as well. Here's an overall safety summary for this particular phase 1 trial with this B7-H3 antibody-drug conjugate. In the far right, you can see the total in terms of safety, and a high percent of these patients will experience adverse events, and you can see here grade 3 or higher, whereas 43% treatment emergent. The percent of patients that discontinued though was only 8%. Dose interruption is about 22% of the overall population, and about 10% with dose reduction. There was only 1 death in the data that was displayed in this presentation, and that was due to interstitial lung disease. You can see here, of course, the small cell lung population numbers were slightly higher, as you would expect in a tougher population. And here are the particular adverse events that we see with this particular B7-H3 antibody-drug conjugate. As you can see on the far right, the percentage, the incidence is there, and nausea, anemia, and infusion-related reactions we're seeing to a degree of 30% or higher. Nausea, eventually on this particular trial, I know it's not on this slide, but we eventually implemented antiemetics, prophylactic, prior to dosing for all patients. Interestingly, a lot of patients, including the ones that I treated, had delayed nausea. So not so sure if the pre-med antiemetics will help those patients, but it was implemented on the trial, and that did seem to help to a degree. But in terms of the infusion-related reactions, that was also later on. Pre-meds of dexamethasone were implemented, and it did seem to improve tolerability. And whenever you have a target, including the antibody drug conjugates, the biggest question is, okay, what is the target? What is the expression? Does expression matter, and how much matters? Right? There's so many therapies now with antibody drug conjugates that are out there, and what percent really matters in terms of response? Well, this was all retrospective, so this wasn't pre-planned, and they tried to obtain as much tissue as possible to do these analyses because everybody wants to know these answers, right? And so on the far right, you can see this is just with the small cell lung population that B7H3 expression just in these samples didn't appear to matter. You can see here that the overall response rate was not higher in patients who had higher B7H3 expression. The PFS, the median overall survival, they were not higher in patients who had a higher expression in the small cell population that had, as you saw, really interesting responses. And the same thing was seen in the metastatic castration-resistant prostate cancer population. Historically, the higher the B7H3 expression, it's thought that it's usually correlated with higher Gleason scores, higher staging, more metastatic disease, more castration-resistant population. In this group, although it's still small numbers relatively, right? 62 samples, 62 patients. Once again, a high B7H3 expression did not correlate with higher PFS, higher overall survival, and higher overall response rate. So interesting. This will have to be obviously followed, and other groups are following this with their compounds as well. So more is to be learned. So this is an ongoing phase 2 trial in the small cell lung cancer population in an extensive stage. These are patients who are refractory to platinum-based therapy, or I should say who have received platinum-based therapy in the past and have not received more than 3 prior lines of therapy. The primary endpoint for this particular trial, this ongoing phase 2 trial, is objective response rate. And so, as you can see here, as we were talking about earlier, Neil, this is an example of what's being done with dosing, right? Where 2 doses are being explored within this particular phase 2, where patients are going to be randomized to 8 milligrams per kilo versus 12 milligrams per kilo, which were the 2 identified doses that were seen in the phase 1 part of the trial.
So I guess people might have been thinking in the past that it might have been randomized 1 dose versus some other therapy,
Therapy.
lurbinectinib or something. I guess you can't really go to 3 arms in a phase 2, but do you think this is like a trend? Do you think that maybe, or are you going to then take the optimal dose and then do another randomized phase 2, or can you go right to phase 3?
Yeah, to be honest, this was probably planned a while. This was planned a while back.
Right.
So now what we're seeing is we're seeing this embedded into the phase 1, right, where these doses are established before a subsequent trial that's being developed to then randomize to standard of care therapy or some other therapy, right? So this particular design is being done in the phase 2, but we're now doing this within the phase 1 trials.
Yeah, I mean, also in this situation, the comparator, standard of care is so bad that it looks like it would. I mean, I don't know if you need randomized data to approve it, but I'll bet that even a 1-arm study will look way better than lurbinectinib. I mean, I'm guess. I don't know. What do you think?
Absolutely. No, I think there's
I even
certain
wonder whether,
comparative drugs that you have a feeling ahead of time that would probably in a higher chance of moving the drug forward.
yeah, like chlorambucil, in CLL.
Chlorambucil comparative
But
trials or
j- j-
sorafenib.
just a Right, sorafenib. But just to backtrack though, in terms of what happened here with the this new agent, I think is really interesting in terms of the fact. So I guess the way you conducted this trial, would you say in general it's the way you normally would do a phase, this kind of early stage phase 1, phase 2 study? But I guess my question is, I'm not sure when it was originally conceived, but obviously with a DXd payload, you got a whole bunch of things to think about if you think it's relevant: nausea and vomiting, ILD, et cetera. So did what they look at, or what you looked at safety-wise, was that guided by previous experience with other similar ADCs like TDXD? Did they do a lot of lung
Absolutely.
screening, for example?
Absolutely. So, as you mentioned, any trial that's being developed nowadays with a antibody drug conjugate, they're built in now where certain criteria have to be met in screening that will very precautiously exclude any possibility of any confusion, for example, with potential of ILD later. So there's screening procedures. They can't have certain findings on the scan during screening if there's ever a concern of even a small potential of confusion with the future pneumonitis or a potential to that's a higher risk of pneumonitis, those patients are excluded now. And so it does make enrollment and screening on trials a little bit more difficult, but it's important to answer those questions, and a lot more is done to mitigate those risks.
So another thing that's been really interesting, particularly about T-DXd as it goes into other tumor types, we did a program at the GU symposium a couple weeks ago, and one of the modules was on HER2 positive, bladder cancer, and I couldn't find any urologic oncologist who had significant experience with T-DXd. So I actually brought in a breast person to say, like, what do they do? Not necessarily that that's what they had to do. And one of the things that came out that I wanted them to see, because when I was asking them, they did not know about it, was what you were talking about before, which is the acute GI toxicity, chemo-like toxicity, which I don't think was appreciated that much in the beginning with T-DXd. First, the breast people got it. I'm not even sure the lung people even have it at this point. But the idea that it was labeled as a severely emetogenic drug. I mean, I saw the GU people react to that 2 weeks ago. They didn't know that. So, for example, it looks like this trial it was evolving as we were learning that. But I guess my question is, do you have any sense about, like, I'm not sure whether T-DXd causes more GI toxicity than, for example, Dato-DXd. I didn't
Right.
hear that much about it. But this drug, did it seem like it was severely emetogenic?
I wouldn't use the word severely because our the regimens that we were using to prevent it and to treat it were not what we do with other severely emetogenic drugs. But the risk is there. So no, this was actually pretty manageable, to be honest. And what's really interesting about this particular drug, which is that it seems to improve as with further treatment. So most of the patients, for example, that I had on this drug, and we had a good number of patients on this, is that most of the nausea and vomiting occurred in the first several cycles. And very interestingly, those high percent of those patients came off antiemetics
Huh.
later after 4 or 5 cycles. So you have to get them through the first several cycles, and they know when to take their ondansetron and so on. But if they really didn't need much more past ondansetron, to be honest, it was manageable with this particular drug.
Another thing is that you didn't actually show data on lung complications. Were there any? I know there's one death there. What was the
Yes.
incidence of ILD?
Yeah, up to this data cutoff, there was only a few patients who have had ILD pneumonitis on the trial. There was one death, as you mentioned, and this is going to be obviously focused on, and this particular phase two, but also the phase three trial that we're about to show as well.
So, one other question I had, which is you were referring to neuroendocrine cancers, you see in the bladder and other places. I'm curious in general, do drugs that work with small cell work? I mean, I see the docs using it. I'm not sure how much data there is. And from your point of view, I mean, could you get a bladder patient to be treated with this, for example?
Yeah, yeah. Unfortunately, a lot of these trials are specific for certain cancers, and they don't have a broad, indication of or allowing, any neuroendocrine tumor. There seems to be an expression difference in different organs, which is why some of these trials will say, small cell lung only. So we are restricted in terms of the data and what we know. I do agree. I wish we would expand some of these trials to allow, if we're seeing nice data with a small cell lung population, have we explored and do we truly know how much expression is needed elsewhere? whether it's GI, neuroendocrine tumors, or like you mentioned, GU and so on. So there's not enough data, unfortunately, because people are the field is really trying to move a drug forward in some of these unmet need disease groups like small cell lung, right? And the focus ends up just being on that. And the incidence and the population, the number of patients who have the other ones are so small that I imagine that plays a role in deciding what diseases and what effort is placed on within that trial, right?
Well, it also gets into, kind of what's the criteria going to be for tumor agnostic approval.
Mm-hmm.
I mean, Pembro with, as, one thing, Dab-Trem for BRAF is another thing. But agents like this, ADCs, like I just
Right.
can't figure it out how they're going to do that. Like even just T-DXd to start with. I mean, you
Mm-hmm.
see HER2 positive, there are too few of so many different, and now they're already out to biliary, but there's even others beyond that. Any thoughts? Has the FDA talked about like what their criteria is going to be for pan-tumor approvals?
Yeah, it's a great question. We struggle with that on the trial end as well, where we're looking ahead and we're trying to make a decision of what trials to bring, right? And some of the targets with the antibody drug conjugates require expression testing. Now that's a big part of what's being involved in the requirements to even get on these phase 1 antibody drug conjugates that you have to test the tumor. Well, these are not commercially available tests that are done, for example, B7-H3 or other targets, right? So now these samples are having to be sent to the sponsor, which takes sometimes several weeks, versus and HER2 and other some other therapies where you can do that. It's very standard to do those testing locally, right? So it does make it a little bit more difficult now, even on the trial end. For these antibody drug conjugates, because now it's pretty much a requirement to test that, and it's done by the sponsor. Hopefully, as these drugs evolve, then you expect them to be now part of a commercial testing. But how do you do that outside of an NGS panel, right? You have to start involving local. Now the pathology offices now have to start doing the testing for these maybe low incidence, markers, and so it's going to really going to up the ante on these vendors on what they're able to do with that tumor tissue, not only NGS but a whole array of IHC testing is going to have to be a big part of what we do in the future. We send off an NGS order on a tissue sample, and we want not only a full NGS panel, but we want um, a set of IHC, a set of markers to be done, all with IHC because of drugs like this for antibody drug conjugates. If expression matters, if you prove it later.
So yeah, that would be interesting to see in terms of what you actually end up showing. And
Mm-hmm.
I guess your next slide, I'm not usually a wagering person. I was sure that data was going to be positive, but it wasn't as positive as I thought it was going to be. But I don't know. I can't imagine this is not going to be a positive trial. Any thoughts?
Yeah, I agree with you. When you have a comparison arm with topotecan, the lurbinectedin, and then amrubicin in the Asian countries, there's a better shot than prior years, right?
But you never know. And also
Right.
the other thing is sometimes you see things you don't expect. Like all of a sudden, data I hear about mucositis. Of course, that was known.
Hmm.
Ophthalmic issues, which I never heard about in lung cancer before. And now all of a sudden, we got not just the drugs you're talking about. You got other drugs and tarlatamab. The
Hmm.
bispecifics and small cell. It looks like small cell is going to be kind of hot in the next couple of years.
Yeah, absolutely. We've been waiting for a lot more development, and small cell ovarian is getting there too, right? But small cell, certainly there's a lot of activity, and especially with this target with B7-H3. But yeah, this is a phase 3 trial in the relapsed small cell lung population, and the primary endpoint is going to be objective response rate and overall survival. But certainly there's a lot of excitement about this. But we learned a lot, not only in terms of these primary endpoints, but also safety. I mean,
Right,
these phase
exactly.
ones are done at centers that are very used to managing some of this toxicity very quickly. Once trials like this roll out, is it as safe and easy and well managed? Is it manageable out in the community and other centers that may not be involved in some of the phase one trials? Because when we're seeing these reactions, for example, you saw the numbers with this. There's over 30% infusion related reactions. Those get handled very quickly because we know it's coming, right? But when you do these trials outside, is it as manageable, and are you seeing a little worse outcomes? And will that affect the positivity, how we view the results of this trial? Yeah, I agree with you.
I've been joking with the lung cancer people that actually, in terms of cytokine release, which I think you see with CD3 bispecific, I think you see it with tarlatamab. But I was
Mm-hmm.
telling them the oncologists are going to be ready for you because we already have bispecifics with CD3 bispecific in myeloma and lymphoma. So hopefully that'll be straightened out. And speaking of that, I assume your units are fully able to handle
Yeah.
CRS and everything else related to
Yeah,
that.
absolutely. We've been doing bispecific antibody trials for several years now, 6, 7 years now, since the beginning of of when those drugs were being developed, and we had to do that. Every center in the country had to do that. Where some of the transplant centers had a little easier time, right, because they had the hospitalization procedures already in place. But and I'm really proud of our units to be able to figure this out as an outpatient when you're not directly connected to a hospital. How do you work with your go-to hospital? And we have a great one nearby. And how do you work with that? And we've had to establish the processes and management and when to call for what and cytokine release syndrome management. And there are now flows and order sets for all of that. Which made it very easy. Every trial that we brought on, everything was set in place, and whether it's at our unit for cytokine release management or in the hospital. And then once the drugs became commercially available within the last year or two, right? Now now the hospital is just used to doing it, and so it certainly has helped establish, make everybody more comfortable when it was already established on the clinical research side, right?
Right. I'm curious too, though, in terms of that question, not to get too far off the topic, but for example, do you feel like all the FCS offices are able to handle cytokine release? Do they carry tocilizumab?
Yep, tocilizumab. So we are in the process of identifying, and we have identified, but in terms of initiating the process, and this is going on all over the country. I'm sure every group is thinking about this: is which offices are best suited to do this. And so some of
Hmm.
our offices that have more infrastructure in place, more staffing,
Hmm.
do a lot of the clinical trial work already. That may already have some of this. Those are the ideal offices, right? Ones that are near hospitals in case when you give tocilizumab in the office or you need more monitoring, we'll have a hospital right next to the office that can take over, right? So these are, so we've identified, we've already started doing it within our practice, identified offices, and patients have already been dosed commercially. But a lot of work goes into making sure you identify the right group, but also the right physician and the right staff, because you have to have go-to people to help manage this and lead that within the office, because it's going to happen 3 4 hours after dosing, right? And so the patient could be just sitting there, but you have to have all that in place. So yeah, we've already started doing that. And once you do it once you have that infrastructure, that plan for with a couple of offices, you can then expand it to multiple, and that's what other offices are waiting for, right? But you got to do it in a stepwise fashion.
So I am curious, like this planning process you're talking about, was that done more
Mm-hmm.
informally, or is there some process within FCS that you can sit down as a group and say, okay, let's figure out how we're going to deal with CAR or bispecifics?
You're exactly right. So everything goes well when you have a formed committees and plan, right? So yeah, for sure, a lot of the personnel that are involved in drug administration within our practice, because we have over 100 offices, right? We have to have a team. We already have a team already in place for just overseeing drug administration in all the offices. So that team was already it was natural for them to take on this role. And okay, how are we going to give these? This is this was discussed years ago, right? Because the luxury with our practice is that we were already seeing these being studied on the clinical research end, and we were
Right,
telling
right.
everyone, hey, we're using tocilizumab every day, right? Be ready in 3-4 years. We might have to start using this and having a process in place in other offices. So that's another benefit of clinical trials, right? Where you're able to educate everybody else and foresee what's coming. And so we've already had those groups in place, the leaders within drug administration, pharmacy, already in place, planning for this with local hospitals, but also our own offices and identifying people. So yeah, it's truly, there's a planning process that has to be done way ahead before you start doing this.
Really interesting. I meant to ask you before, if you get a typical NGS assay right now, do you get a B7H3 readout?
No, unfortunately, it's not commercially available, and so you have to have, if you're involved in the trials, these drugs are only available on clinical trials, right? So the sponsors are the ones who are arranging testing for that. Mhm.
But for this trial, you don't. It looks like you don't need to be tested. I mean, you need to be tested, but it is not a requirement to be positive to
Upfront,
enter. Right,
correct? Yeah. So
right.
far, there's not enough data to suggest that to stratify patients based on expression.
All right, please continue.
Yeah, sure. So another compound that's been studied on phase 1 trials is a MGC018. It's another B7H3 antibody drug conjugate, and this was also presented at ESMO in 2021 by Dr. Shenderoff. And MGC018 eventually was named vobramitamab, duocarmazine. As you can see here from the name, duocarmazine is the cytotoxin, is the payload for this particular B7H3 antibody drug conjugate. So within this trial with vobramitamab, this phase 1 trial, typical dose escalation followed by an expansion phase, in particular metastatic castration-resistant prostate cancer, as well as non-small cell lung cancer. And the primary endpoint, of course, in this phase 1 trial was safety and tolerability. And within this population, here's some subsets, some data, and as we've seen with other metastatic castration-resistant prostate cancer trials with B7H3 antibody drug conjugates, you see here reduction in tumor within this population for the ones that actually have measurable disease. And obviously, there were several patients when this data came out that were still ongoing. And then this is always an impressive curve, impressive graph that we see with all these B7H3 antibody drug conjugates is the change in the PSA, and we see that with this particular B7H3 ADC, and you can see here PSA 50 changes in a high percent of patients. And the same trend was seen with this trial in non-small cell lung cancer. And here's the overall safety with vobramitamab, duocarmazine, in this particular phase 1 trial. Similar to other ADCs, a high percent of these patients will have adverse events. However, as you can see here, only 7% on this trial, a small number, right? 86 patients in this particular data set. 7%, only 7% needed to be discontinued due to an AE. 20% would needed dose reductions, and about 45 didn't need to be interrupted though. And here are the particular adverse events with this particular B7H3 ADC. As you can see here, fatigue, but really cytopenias are the bigger ones with this particular ADC, neutropenia, anemia, thrombocytopenia, and the rest is there, all related to the cytotoxin, the payload, nausea, pleural effusion, round up the rest of the AEs there in terms of grade 3 or higher. There's a different way of looking at this. And as you can see here, most of the adverse events were low grade, right? Grade 1, grade 2, in terms of treatment related adverse events. Small numbers in terms of grade 3 or higher, but certainly manageable. So here's the ongoing phase 2 trial looking in the metastatic castration-resistant prostate cancer population, where once again randomizing to different doses, to 2.0 mg per kilo and 2.7 milligrams per kilo. And the primary endpoint here is radiographic progression-free survival in this prostate cancer population. Up to one prior docetaxel containing regimen is required in terms of eligibility. And the patients can be stratified based on visceral disease, prior taxane, and region. And lastly, this is the third compound that we'll talk about. It's another B7-H3 antibody drug conjugate, HS20093. And similar to some others, the payload is a topoisomerase 1 inhibitor. And this escalation design, as you can see here, is very similar to others that we've talked about today, where 8 milligrams per kilo and 12 milligrams per kilo were the doses that were moved forward. And then in the expansion phase, typical non-small cell lung cancer, small cell metastatic castration-resistant prostate cancer, and so on were studied. And here are the baseline characteristics as well as safety and tolerability. Similar to others, based on the payload, the cytotoxin, the dose-limiting toxicities were cytopenias, as you would expect. The MTD was found to be 12 milligrams per kilo. Most of the adverse events that were seen with this drug, similarly to others, were all low grade. Not too many grade 3 or grade 4 events with this particular antibody drug conjugate. Here's some efficacy results. Small numbers, right? But similar to what we've seen with other compounds. Non-small cell lung cancer, small cell lung cancer were certainly areas that showed some interesting efficacy, as you can see here in the waterfall plot. Objective response rate of 64%, median progression-free survival of 4.7 months in a heavily pretreated population. And on the right, you can see the small cell lung data. Small numbers, but trend is going towards what we've seen with other compounds. And this is an ongoing phase 2 trial with this compound, this particular B7-H3 ADC HS20093. This is in the treatment-naive population, so extensive stage small cell lung cancer population, where the primary endpoint is going to be an objective response rate up to 18 months. And then the key secondary endpoints will be PFS, overall survival, and duration of response, and safety, of course. But yeah, this is up front now, so the field is certainly moving quickly.
Upfront small cell? Like they're not going to get chemo?
Yeah, that's the way this is designed. We're not participating in this particular trial, but this is the way it looks like it's designed. Yes.
It's interesting. I mean, like if you kind of view it as a window kind of trial, maybe, if they're, I don't know how many people are asymptomatic with metastatic small cell, but I could see it like a window trial, maybe if they were asymptomatic, which I don't know.
Asymptomatic, anyhow, a certain population.
Yeah, small cell, asymptomatic. But anyhow, a couple of final things just to sort of bring it together. One thing, I'm just kind of curious, like you talked about 3 different ADCs with the same target. Mm-hmm. There's a lot more data in the first one that you talked about. But I just wonder if you could kind of like capsulize, and just as an example of how you view research in progress, how do you view these 3 ADCs at this point in time? Like, well, this one, looks like it's almost, it looks like it's very likely to be beneficial. This one, it's way, way too early, but the toxicity looks good. Like any sort of capsulized view of, even though I know you're not necessarily participating in all these, but what's your view of them in terms of where they're at?
Yeah, we're participating in 2 of those 3, and the first 2 for sure. And there's a lot of combination work, in particular with the second drug, with other immune agents, PD-1, CTLA-4, bispecific antibodies, and so there are ongoing trials with that. So more is to come as far as where these drugs will be. Very exciting, all 3. I mean, I think that's the overall general consensus, right? You're seeing nice efficacy. Generally manageable, and we just need more numbers, right? We need more data from these planned ongoing trials. But I think they're all equally exciting. I think one, obviously, there's one that's the first one is a little further ahead, right, than the others, and really the numbers are going to be higher with trials. You're going to get more data for trials that are larger, and which is what we saw with the first ADC. So it's hard to compare all three, right? Who knows if with more data if the other two are going to have as much efficacy as the first, but I think they're all equally exciting and all manageable, right?
Any thoughts? This comes up, in bladder cancer, where first line therapy now is ADC plus IO, enfortumab and pembrolizumab. Any thoughts? There's situations like that where it looks like ADC plus IO is better than chemo plus IO, even though
Mm-hmm.
ADCs are supposed to be chemo, targeted chemo. Do you
Right.
think that's the case, that in some way you're seeing like some synergy with the ADC that you might not see, with other agents? And do you think there's a mechanism that explains why an ADC might be more effective combined with an IO?
Yeah, I think it's certainly an area of interest and really trying to explain. I think a lot of it has to do with tolerability, right? I mean, some of these ADCs are much easier to combine with other agents, which is why the combination trials have taken off and why perhaps we're going to be using a lot more of those combinations than chemo IO combinations, you know. And so I think that's why we're seeing a lot more a movement for an interest on combinations with ADCs because it's just easier to do. These drugs are tolerated better. In terms of efficacy, there really isn't data to suggest why, if there's true synergy. I think a lot of the combination data that we see is a lot of additive properties, right?
Right,
Um,
right, yeah.
but certainly better tolerated than what we would traditionally see with chemo combinations, which is why these combos are making it, right? But to your point, I think these type of compounds and others, in terms of the antibody drug conjugate family, will start surfacing and moving from the refractory metastatic populations earlier and earlier, like we're seeing, as you mentioned, in the bladder population, right? And so we're going to start seeing that in other diseases, and those trials are ongoing right now, first line, right? And so that's an exciting field. And I do foresee a lot of these making it in that arena in the right population once we can target who that drug is best for. I think that's going to be the key.